It's not the end, it's the beginning. Treating macular hole is a day-to-day practice for a vitreoretinal surgeon. Addressing anteroposterior and tangential traction by classic ILM peeling is the key of success for macular hole surgery. But even in the best hand, this can fail and results in non-closure of hole like this. For larger holes, inverse flap technique is adopted for better hole closure than classic method. But in a failed case after peeled ILM, the option is to plug this residual hole with free ILM flap like this case. Few surgeons have tried with lens capsular flap, autologous blood, etc. In these cases, hole is closed, but SDOCT analysis shows it is filled with scar tissue only. Then a new idea came to my mind. If we can replace it with retinal tissue so that the gap can be filled with functional retinal graft. We have designed a series of trephine of different sizes. Preoperatively, after measuring the whole size, we choose a trephine of 100 micron larger size. After residual vitrectomy, a suitable area is chosen and retinal trephination done with gentle rotation. The graft is freed with a scissor and hold with the forceps at the margin with utmost care. The graft is placed over the hole gently with photoreceptor side down, then tucked with soft tip cannula. This is done under air and residual fluid is taken out. Donor site lasered properly, followed by gas tamponade. Curiously, I was waiting for the result and I saw the hole was closed with the graft and the well taken graft was having architecture somewhat similar to adjoining area. Now a question arises, is the graft functioning? To understand, we did multifocal electroretinogram and wow, it's amazing response at macular area showing significant macular spike. And we performed Humphrey visual field of 10-2 as well, which also showed near normal foveal threshold of 25 to 27 decibels. Till now, we have done 7 cases with minimum follow-up of 1 year up to maximum of 3.5 years. In this series, we have 70% cases with graft in place, vision improved in 40% cases and rest with stable vision. Though the number is small, but being a rare condition of primary failed surgery, number 7 is significant enough for establishing the fact. Literature says few surgeons have tried putting autologous retinal patch graft in these cases, but they have used larger size graft without trephination, which probably acts as a scaffold. There is no end-to-end touch. In our method, predetermined size of retinal trephination done and tucked into the hole to have end-to-end touch. and we hypothesize that an aberrant regeneration takes place at this graft host junction. To prevent any hindrance into it, we did not use any viscoelastic agent or liquid perfluorocarbon. To show you the comparison, this is a multifocal ERG in a normal macula. Here it is a case of closed hole with classic ILM peeling. In this case, it is failed hole closed with ILM free flap, and this is our case of macula grafting. Please do see on a single chart. This encouraging multifocal ERG response indirectly proves our hypothesis of aberrant regeneration of neural connection. Also, automated perimetry supports this fully. The key of success here is harvesting exact size of retinal graft by trephination and not using any substance which can hinder end-to-end touch. A larger series can open up a new horizon of retinal grafting. Thank you.
Thank you so much, Rupak. Great innovation. How do you explain those two spikes in your ERG? So in normal you showed one spike, and in your graft you showed two spikes. Can you just go back to that picture? Because that's something very, I don't know whether that is a spike of vision. If there are two spikes of vision, no, it's in the end, you know, when you're comparing.
Then tucked with soft tip cannula.
No, just
Hypothesize
go ahead.
that we did not use any viscoelastic AT flap, and this is our case of macula grafting.
Go to the comparison of all.
Please do see on a single chart.
This is the one. I just want you to explain this, that the grafting has
This one,
two spikes.
this encouraging multifocal
Hey, please
ERG
stop it.
response
Stop it. I just want to
indirectly proves
what I want to know
our
from you.
Yeah, so but that is actually, one is at the foveal area, the other is the perifoveal area. So which is quite far from the behind which the spike what you are seeing is a perifoveal.
This is only at the area of fovea.
Yeah, but
if that does that mean there are two potential vision present at that point, because you implanted a piece of retina,
yes,
and it has developed two close by.
The other one is a perifoveal area which is giving another response.
But that response, if it was there, that's supposed to be at foveal area. That particular response is not there in normal retina.
Correct.
Anywhere. So if it is perifoveal, you should be flat. You know, the green.
Yes.
The red spikes which you have shown, it suggests that there is another parafoveal, or into the graft area, you are developing another foveal response.
Yeah.
I mean, I couldn't understand it anyway. If you can explain to it, fine. Yeah.
Can I? Yeah, this is a nice observation. So probably the area which is the graft area which is sitting there, so the response from one area and the other area may be different. So that's why we got it of two spikes of the different areas.
So in your series, I think now you have a bigger series.
Yeah.
And 7 cases, only 3 cases the graft was in place. So in your extended series, what is the success rate like? Because there's a learning curve, I'm sure, and it's, so yeah.
So if we, yes, this is, if you remove those areas, the graft anatomical success rate is almost near about 85 to 90%. I think
now your rate
last
has
1 year
improved.
I have lost in 1 case.
So one is like you first measure the size of the hole, and then you take the trephination or trephine accordingly.
Yes,
That
15% increase approximately, and then I
so
take the
you have
trephination.
all those trephines with you.
Yes, of different sizes of trephine is there.
And how big hole you would like? What will be the maximum limit you would like?
So as of now, I have prepared till the inner diameter of 1200 micron.
1200.
is available as of now, but we can make even larger also. We can
And
make it
which is the area which you select for trephination? Like,
Just-
because the thickness from the foveal center, and if you are taking a graft, retinal graft from periphery, the thickness will be different.
So this is what I have chosen because of the convenience of the surgeon. Is just above the superior arcade, so which is not within the macular area per se, but again it is just above the macular area, so that you can avoid the scotoma, and the cone concentration is not that less than the compared to the periphery. So what I have chosen is just above the superior arcade.
But the thickness of the retina in that area compared to fovea will be
Fovea is
different.
different. Is different.
Thank you.
Thank you so much, Rupak, for a very wonderful presentation.